right, so today I'm going to be talking about the Newborn Screening Saves Lives Act of 2007. On April 24, 2008, then President George W. Bush officially signed into law the Newborn Screening Saves Lives Act of 2007. The purpose of this act is to facilitate the creation of federal guidelines on newborn screening, to assist state newborn screening programs in meeting federal guidelines, to improve education, outreach, and coordinated follow-up care, and to improve the laboratory quality and surveillance for newborn screening. Newborn screening is the process of testing and examining newborns for genetic or metabolic disorders such as cystic fibrosis before those symptoms are actually seen. And this is done by taking a blood sample from the heel of the newborn and examining the blood. This policy would affect all families that have their baby in the hospital. The problem leading to this act is that many parents may not realize the importance of screening or what screening even is or what screening is looking for. Also problematic is that screening guidelines and regulations vary from state to state. At the time this act was introduced, only 15 states and the District of Columbia required that infants be screened for all 29 of the recommended disorders. And those chosen 29 disorders were recommended in a report by the United States Department of Health and Human Services. That's how they chose those 29. An estimated 1,000 of the 5,000 babies born every year in the United States with one of the 29 core conditions potentially go unscreened through newborn screening. If diagnosed early, these conditions can be successfully managed. This leads to a better understanding for the parents and potentially better quality of life for the child and hopefully a follow-up care and treatment plan. The act itself is broken down into 7 sections, Section 1 just being the short title of the act itself. Section 2 is titled Improve Newborn and Child Screening for Heritable Disorders. It amends the Public Health Service Act to authorize grants to entities that are eligible to help improve both state and local health agencies in providing screening and follow-up care to the babies and children who either have or are at risk for heritable disorders. The grants would also go to provide training and education to both the healthcare and lab personnel actually working with the newborns and families, and bring educational lessons about the whole process of newborn screening and all that entails to the families and to support groups. Finally, to establish, keep, and use a system to examine and organize treatments related to the disorders that may be found. Section 3 of the Act is evaluating the effectiveness of newborn and child screening programs. This section amends the Public Health Service Act to authorize certain amounts of money for each fiscal year, starting in 2008, going through 2012, that would help look at and examine the effectiveness of newborn and child screening programs in lowering the morbidity and mortality caused by congenital, genetic, or metabolic disorders. Section 4 is titled Advisory Committee on Heritable Disorders in Newborn and Children. This section expands the duties of the Advisory Committee on Heritable Disorders in Newborns and Children to include, number 1, making recommendations that include the heritable disorders for which all newborns should be screened, 2, developing a model decision matrix for newborn screening expansion, and 3, considering ways to ensure that all states attain the capacity to screen for the recommendation. It also sets forth guidelines for the Secretary to make a decision on Advisory Committee recommendation, and it requires that the Advisory Committee continue to operate during the 5-year period beginning on the date of the enactment of the Act. Section 5 is titled Information Clearinghouse. This section requires that the Secretary of Health and Human Services, along with the CDC, establish and keep a central clearinghouse and make it available through the internet. Parents and families of the newborns will be able to find educational information and resources and family support information along with screening services that are available specifically for their state and all current research about the conditions that are being screened for. Also, the families can see the availability of federal funding for screening. Section 6, Laboratory Quality and Surveillance. This again requires that the Secretary of Health and Human Services, along with the CDC, ensure the quality of the screening laboratories and any other materials used in testing, and also to examine the performance of any new screening tools that may come along. This section also requires the Secretary to make an interagency coordinating committee on newborn child screening and make their recommendations on programs to collect, analyze, and make available data on certain heritable disorders, and the establishment of regional centers to conduct applied epidemiological research on effective inventions for preventing the poor health outcomes resulting from such disorders, and to provide information and education to the public on such effective interventions. Finally, Section 7 is called contingency planning. This 7th section discusses developing a national contingency plan if a health emergency were to occur, and this plan must be made no more than 180 days after the bill is enacted. The plan has to involve the processes of collection, transport, shipment, and processing of all the blood specimens, and then relating of results to the doctors and families of the newborn and children. The contingency plan must also include plans for the confirmation of positive results and education for families all about newborn screening. This section also discusses future research for screening, which is to officially be known as the Hunter Kelly Newborn Screening Research Program. In 1963, Massachusetts became the first state to mandate statewide screening, and at a recent event celebrating the 50-year anniversary of that, a woman named Madeline, now 22, shared her personal story. At the time of her birth, Madeline's mother didn't even know about screening, but it was done to her daughter at birth. 7 days later, she gets a call from the physician saying that everything's not okay. She finds out that the test had come back positive for congenital hyperthyroidism, and if left untreated, it could lead to developmental delays or intellectual disabilities. Because it was caught so early, though, in life, Madeline was able to be treated and now just recently graduated magna cum laude with a biology degree. In 2012, R. Rodney Hall wrote a review of current newborn screening for the CDC, and now more than 90% of the 4 million babies born in the US are screened. Since the act was passed, there have been 2 more conditions added to those 29 that were already set. These include severe combined immunodeficiency and critical congenital heart disease. There are still others that are being discussed back and forth whether to add them or not. Hall writes, assessing the health benefits and return on investment of newborn screening has its challenges, given the diversity of conditions and their varying outcomes. But overall, screening and treating disabling conditions can help reduce healthcare costs. Looking at the goal of long-term follow-up, that hasn't been quite as successful, with only about 56% continuing in that process. Hall gives the example of newborn screening for hearing loss. It increased from 46.5 in 1999 to 96.9 in 2008, but the data in follow-up testing is lacking. In 2009, nearly 45% of infants who did not pass screens lacked documentation of a follow-up assessment. Screening is a very beneficial process to the current and future health of newborn children, and the Newborn Screening Saves Act Live of 2007 brought needed structure, education, and future research goals to light. It's now easier for families to be helped and educated about the screening process and treatment of possible diseases. It has also helped in the control of state-by-state requirements and given specific testing requirements. The process isn't perfect, however, and there are still some challenges. Clinical challenges include a shortage of experts trained to diagnose and manage conditions detected by newborn screening. Laboratory gaps and opportunities center on detection of multiple conditions using a single test. Expansion of automation to reduce testing costs, and extension of new molecular methods to all disorders. Also, screening isn't the end-all be-all. Just because a baby has been screened doesn't mean that's the end. Usually with a positive diagnosis, like I've said before, further care must be maintained, and families still need to be educated about diagnosis and treatments. It's important for both families and parents to be knowledgeable about baby's first test.